Alrighty. Good afternoon, everybody, and we will discuss episodes of CARE today. We are working with, I'm Bill Golden from Arkansas Medicaid. We have a number of folks from Blue Cross, Medicaid, GDIT, HP, and others here. We are recording this webinar so people can refer to it on the web at a later time. And this is the third town hall that we're putting together about potential new episodes of CARE. We've had one discussion about urinary tract infections in the ER. We've had one on pediatric pneumonia. And today we're talking about hysterectomy. And what we've done is have a very quick overview of the episodes, which is kind of the same for each of the discussions, and then a discussion about the episode itself. We choose the new episodes based on volume and potential practice variation. And so very quickly, it's all about the triple aim, and we're trying to work with the episodes for a sustainable healthcare system that would improve the individual experience of care, population health, or groups of patients, not just an individual patient, but also work to control the cost curve to make an economically sustainable healthcare system with better outcomes. This has been in place since about 2011, when we partnered with Blue Cross and Call Choice and talked about ways of creating a sustainable healthcare system that was not just cutting enrollments, increasing deductibles, co-pays, or raising premiums and taxes, and without getting into intensified utilization review, but rather work to change incentives and rewards to reward efficient care and outcomes. That is to say, pay people more who get good outcomes at a lower cost. So the framework has been to develop episodes of CARE or change incentives for acute and post-acute care, which is the middle circle on the slide. Right here, if you can see the circle, the arrow, which is what the episodes look at, basically surgeries and acute hospitalization. Supportive care, which gets into long-term care, care of the disabled in the community, and then the screening, prevention, and chronic disease management, which has been our very active and very successful medical home program. We have been one of the few states in the country that got recognized early for doing innovation and payment reform. We received one of the first implementation grants from CMS to implement payment reform. You can see the others are a bit north of us, but since this grant is now in our third year, we now have other states have received grants like Tennessee and Ohio, which are replicating a lot of what we've done, and other states are getting these grants as well, in Washington State, Colorado, and a few others. Our framework for episodes has been to look at the medical literature, national guidelines, talk with local clinical advisors, and develop a framework to look at average cost of care for high volume cases. What we have done is not go into a prospective bundle, which many people talk about, where a single check is cut in advance, that everybody gets paid the same for an episode of care, but rather we are looking retrospectively at a risk-adjusted patient journey so that everybody gets paid for fee-for-service just like they do today. But at the end of the year, we look at the average cost, risk-adjusted cost per case, and compare how individual providers provide care during the year. So each one of these bars would represent a provider and their book business for the year and their average risk-adjusted cost per case. So if they were below a commendable line, we shared savings with that provider. 50% of the savings below this line would go to the provider and 50% back to the payer. People who were not particularly efficient would be up here in the red zone, and so they would share the expenses above that line, about 50%. Everybody else would be in the gray zone, which would be no financial changes. So the way we designed the episode, 80% of doctors or providers or hospitals would be revenue neutral or winners at baseline, and if you changed how you performed, we could have everybody being revenue neutral or winner based on the program that we've done, and that would still mean that the healthcare system saved money because the curve had shifted away from expenses to savings. We have been doing a lot of data crunching. Both Blue Cross and Medicaid and others have created report cards which show on a quarterly basis to providers how they're doing, what their patients look like, what their average cost per case looks like. We've been giving them detailed snapshots of where the dollars go in the patient journey, so you can tell at an instant whether your management of patients consumed more medications or laboratory work or ER care or inpatient days. So you could quickly find out where you wanted to focus your attention on say, rethinking your standard operating procedures for delivering that service, in this case here, a total joint replacement, but today we're talking about hysterectomy. So here are some of the early episodes: orthopedics, obstetrics, heart failure. We have done a lot of data crunching. This is just Medicaid. Over 300 million claims. I'm sure Blue Cross has done similar kind of data crunching. Lots of reports, a lot of work to give providers a detailed snapshot of where they are, where they've been, and how they can do better in the future. So this is a continuous learning process. We're giving data to providers to let them figure out how to do better, while we are getting feedback to our vendors, such as Hewlett-Packard. They're getting calls for feedback to the providers with questions, as well as to our data partner, GDIT. So as we give feedback to the providers to have them improve their care, we're getting feedback from the provider community to help us improve our reporting, our information, and to make the information much more relevant and useful for the provider community to proactively change how they deliver care in our state. So let me stop there. Steve Spalding from Blue Cross is here. I don't know if you wanted to make any comments, Steve, about the Blue Cross experience with episodes of care.
Thank you, Dr. Golden. Yes, we are very interested in pursuing the episode initiative along with Medicaid for a few reasons. One of the reasons is that we think there's great value in consistency in expectations and measures in the delivery system, so that providers of care don't have to so much try to figure out what kind of coverage a patient has, so that they can understand the different rules by which a health plan wants that patient to be managed in order to maximize the value of that experience for the patient. So by creating consistency in these, it can help us smooth administrative processes for providers. It also creates enough volume for the providers to actually change some of their processes and cultures, to change the way they deliver care from one that is mainly focused on activity as opposed to focusing on results. And so Bill probably will tell you later on in the presentation that CMS is watching this very closely. It has been showing pretty successful outcomes so far, and they're interested in possibly bringing the Medicare population into alignment with this. And so what we hope with all of this is that we can provide the framework that won't be very prescriptive in how the results are created, but will leave enough room for innovation in the system, so there can be creative value-based innovation that allows payers to pay providers of medical care better as opposed to just less, and also resulting in a better outcome for the patient. At least that's our goal.
Thank you, Steve. And again, the data we present to the provider community is not just what a physician or a hospital orders, but the entire journey of the patient, all the people, all the providers that touch the patient, deliver a service. their care is in the report cards. So it really is a comprehensive look at what happens during the course of care. Really a view of healthcare resource use that providers, doctors, and hospitals have not seen in the past. So anyway, let's move on, unless there are comments or questions from the audience here in Little Rock or at a remote site. So anybody have any comments or questions at this time? So the patient journey, oh, we have a comment? Okay, I don't hear you if you're there. The patient journey. It's an echo. Okay. The patient journey, we can look at an episode of care. You have the patient journey. You have a principal accountable provider, which in this case will be the surgeon, which would be the OBGYN in most cases. We have to figure out what elements of care is included in the total cost of care, potential practice variation activities, what triggers the episode, when does the episode start, what are good risk adjustments, such as diabetes or morbid obesity, the duration of the episode, when does it end, what kind of cases get excluded, and we'll see here that we'll be excluding radical hysterectomies or hysterectomies related to cancer therapy, and then a variety of quality metrics, both for improvement, for information, as well as for accountability. So hysterectomy, we have a number of key issues. One is the underlying diagnosis. Most folks the majority of them are being done for fibroids, which may or may not be responsible for dysfunctional uterine bleeding, but uterine bleeding is another common reason for hysterectomy. We can show you the age, volume, at least in the Medicaid population a little bit. There's also the issue of pelvic relaxation or need for potential bladder procedures to improve the pelvic organ integrity and dealing with issues of urinary symptoms that patients can get as they age. There is a fair amount of practice variation, which is to say you can approach the operation from a number of different techniques, laparoscopic, robotic, vaginal hysterectomy, abdominal hysterectomy. Now, some of those techniques will vary depending on patient conditions, such as obesity, as well as surgical skill. The ACOG recommends that people should try vaginal hysterectomy in most cases because it is because of reduced morbidity as well as reduced cost and complications. But again, it is a rather mixed picture about which technique is used. There's also a variety of preoperative care. Patients who present with dysfunctional bleeding may have several months of different kinds of techniques being given: hormonal therapy, uterine wall ablations, hysteroscopy. So there are all sorts of issues that may occur. There may be ER visits for bleeding, transfusions, which add to the cost of care, something that we may profile to look at whether an earlier surgery could have been a more efficient journey for the patient. Then you get into the issue of perioperative management, issues related to transfusions, use of antibiotics, wound infections, wound dehiscence, deep venous thrombosis, prophylaxis, pulmonary emboli, etc. And again, this episode of care will not include cancer management such as ovarian cancer or invasive cervical cancer. Here's a distribution, at least on the Medicaid side, of the cases being done. The most common procedure was total hysterectomy. Total laparoscopic hysterectomy is very common, and you can see a variety of codes that were used for the hysterectomy. Here is an age distribution. Most folks are over the age of 30, and again, very few are under 30, though that does happen here and there. You can see the mean spend goes up as a patient ages, and that may be because of concomitant procedures for bladder repair or bladder suspension. as the patient ages. Let me stop here for a second. I see Matt from Blue Cross is here. Do you have any data that you want to share as well about the distribution of patients in the Blue Cross episodes?
Yeah, we've got a little bit. I think Jessica and Mallory have some in front of them. I do know that we saw probably about tenfold the number of episodes that you're showing here. We had around 2,000 hysterectomy cases. Ours leaned more towards the 49 to 50 age range. So I think we may just be skewed slightly older, but roughly not too far off from the overall distribution.
Do you have any distribution about vaginal hysterectomy, laparoscopic, et cetera? I haven't looked at
Yeah, I do think, if I remember correctly, we're showing around 55% in the laparoscopic category. And I think you guys had more kind of spread between the three categories with leaning towards laparoscopic. So
we were pretty much, I think we were like 1/3, 1/3, 1/3.
Right.
Okay. So the patient journey here, you have the issue of the preoperative diagnosis. When did it happen? How was it managed? One of the things we're going to look at is we may likely, in the Medicaid episode, use the operation as the trigger when the physician takes the care of the patient. We will likely look at the laboratory work and activities for the 1 week prior to the operation, looking for the preoperative workup. We may likely profile the activities and procedures and visits of the operating physician in the previous year to give feedback to that physician about the total spend for that patient during the patient journey if they were managing that condition prior to the operation. So we want to look at some of the non-operative management techniques done in the year prior that would not be part of the cost of the episode, but would be something we could profile and give to the operating surgeon for potential also sharing with our primary care community in the future. We want to look at the success of the operation or the success of the non-operative management or the issue of ER visits and transfusions for conditions related to the ultimate cause for the hysterectomy. We have the issue of the surgery itself, the comorbidities the patient presents with. We'll be doing some risk adjustments. We'll also be cataloging the different comorbidities for a particular surgeon in their book, in their portfolio of hysterectomies for the year. We will give a breakdown of the techniques used by the PAP, the frequency of bladder suspension and the age of the patients getting the bladder suspension, also things like the average length of stay. We'll be looking also on the patient journey of the follow-up care, persistence of antibiotics, follow-up visits, follow-up need for complications of management such as wound infections, etc. So that's going to be the patient journey. Some of it would be in the cost of the episode. Some of it will be for a specialist profile that we will share with the surgical community. As Matt had mentioned earlier, here's sort of the breakdown of the kinds of cases being done. This is the surgical approach on the Medicaid side. So about 135 vaginal hysterectomies, about 138 abdominal hysterectomies, and about 120 some laparoscopic hysterectomies. And you can see the episode counts as well as the number of PAPs doing the procedure. Again, laparoscopic tends to have higher cost but lower lengths of stay. Vaginal hysterectomies tend to be lower cost, probably because of a lower length of stay as well. Here is a early, probably non-adjusted cost profile of Medicaid PAPs, average cost per case. You can see the distribution. We have about 32 PAPs with at least 5 episodes, about 320 episodes at $1 million. And as we heard earlier, On the Blue Cross side, they have about 2,000 episodes of care. So you can see that this will be very heavily skewed toward volume on the Blue Cross side of the ledger. And again, for those who don't track these, the episodes are separate. Medicaid runs an episode separate from Blue Cross, separate profile, separate costs, but the journeys are available on a common portal, so you can get your Blue Cross data. You could get, if Call Choice does it, their data and the Medicaid data at the same location, but there are separate report cards for each payer. So the kind of metrics we're going to be looking at, again, we mentioned this earlier, we'll be giving feedback in terms of surgical approach, which techniques each surgeon are using and their preponderance of their style, preoperative procedures, preoperative emergency room care, concomitant procedures like hysteroscopy and bladder suspension, length of stay, readmission rates, post-op infections. In terms of quality metrics, we'll be looking at persistence of antibiotics post-op, the percentage of patients who are getting antibiotics at discharge. Most patients should not be going home on antibiotics, but should be having antibiotics completed prior to really within 48 hours of surgery. There is an article that appeared in March 2013 that talked about complication rates. So I believe that most folks are finding that there is a surgical wound infection rate of about 10% on average, though it can range as high as 22% for abdominal hysterectomies. We have fairly low rates of DVT, very low rates of pulmonary infections after hysterectomy, usually less than 2%. Urinary tract infections can range from 0 to about 13%. So again, room for a lot of variation, but the post-op infection rate is not 0, but it is certainly something that is fairly modest. And we have issues of urinary tract injury rates. About 1 to 2% of hysterectomies have what they consider to be a, quote, major, unquote, injury to the urinary tract system from the surgery, most of which occur during abdominal hysterectomies, during laparoscopic hysterectomies, but they are present in others. So that's kind of the big picture. Any other comments from Blue Cross on the episode of the patient journey? Do we have any comments and questions from the audience about the framework or the vision about how we will be developing data and sharing that data to the provider community and the PAP? We will also be clear that this episode, at least for Medicaid, would be going through the promulgation phase of the review process with the legislature in October, with expectation that there'd be implementation of this episode in the spring of 2016. So there is quite a bit of time ahead for follow-up. We'll probably, as this matures and we have more specific data in terms of how this will be presented, we'll do a webinar by telephone and WebEx, so we can share with you additional information as we gather additional feedback and as we start to put more of the programming into place to put this episode into our reality. We've had discussions with local experts, and we will have another discussion with them following this webinar to go over some of the final decisions with them based on the early feedback we got from them, as well as to kind of wrap up some of the odds and ends that we will do to make this episode a reality. And that kind of is the big picture. So any further comments from you, Steve or Matt from Blue Cross? Okay. Any other comments from folks in Little Rock or at a remote site? And again, we will be doing follow-up with the Medical Society, the Hospital Association, and other folks as we get feedback and comments by email and other venues. So at this point, we hear no other comments. I'd like to thank everybody for paying attention, for